Over to you, Fahim.
Okay. All right, we are
hello,
live.
everyone.
Hello, good evening.
Good evening. This is Walaikum Assalam. This is Dr. Faisal Nawaz from Batch 1 of Ziauddin University Alumni. I welcome Dr. Saqib Ghani and Dr. Amir Burney on behalf of Ziauddin University Alumni for this interesting session. For today, we'll be talking about some challenges faced by cardiologists during these times and the challenges in general by the frontline workers in UK. And I believe Dr. Amir Burney is going to elaborate on these in shortly. So over to you, Fahim.
Yeah, we are pleased to have both of you on board, and Dr. Amir Burney will be especially highlighting on the role of Association of Pakistani Physicians in Northern Europe, and there's been a lot of active work on part of this association where we would love to know about and what role they are bringing in and what facilities and support they're providing to especially Pakistani descendant doctors in UK and Europe in general. And we'll be glad to share our input in increasing the number of membership through our platform so that Ziauddin medical graduates can also join in your association to make it grow bigger. Yes. So I'd like to first invite Dr. Saqib to give us a little introduction, and then Dr. Amir Burney next, so he can give his own introduction.
Well, Fahim and Faisal, assalamu alaikum, and thank you very much to Ziauddin University Alumni for inviting me and my colleague Amir Burney on this very important session. So I'm a consultant cardiologist in NHS. I'm an intervention cardiologist working in Darren Valley Hospital, which is just at the outskirts of London. I've been working here for more than a year. But just to summarize, I actually graduated from Karachi from Ziauddin Medical College and moved to UK in 2005 and been here since. So I've been an active executive member of my college alumni in the UK. And in the last few years, been very active with APPNE, which we'll touch base on a few moments later. So that's just my summary in a nutshell.
Dr. Burney.
Dr. Amir Burney.
Assalamu alaikum and good evening to everybody who's listening in. So my name is Dr. Amir Burney. I'm a orthopedic surgeon, used to be an orthopedic surgeon and a sports and exercise medicine doctor. Now I'm a full-time academic. I work for one of the leading medical schools in UK as their academic for clinical skills and their director for studies. APPNE is as I said, we will talk about it later. So I'm the current president of the Association of Pakistani Physicians of Northern Europe. I also belong to Ziauddin Medical University, which I graduated from many years before Saqib did. And then we are also part of the Dow graduates of Northern Europe alumni team as well.
All right. We're going to start our session with Dr. Being a cardiologist, you are one of the frontline workers, especially in the healthcare settings during these COVID-19 times. So our first question to you, Dr. Saqib, would be, what has been the experience on your part, especially in this COVID-19 pandemic as a frontline worker?
Okay, I mean, we know this pandemic has actually spread all parts of the world, pretty much, especially the Western world, Europe, and China, and now spreading in Asia as well. UK, unfortunately, has seen the second highest number of deaths related to COVID. We are approaching approximately 35,000 to 36,000 deaths, and that tells you the impact of the impact it's had on for frontline workers. So it has been quite busy. March and April were definitely the busy time, and we peaked somewhere in the first and second week of April, where hospitals had the highest proportion of patients admitted with COVID. So just from my personal experience, I mean, I work in a medium-sized district general hospital, where we had approximately 1,000 cases in these 2 months, with about 18 to 20% inpatient mortality. So the positive side is that we managed to discharge more than 800 of them successfully. So that's just a frontline experience. what we noticed that was COVID patients, it's a new disease. So we were learning as time was going by. So every week we're learning something new. Patients were presenting with different symptoms, and that posed new challenges to the frontline workers in diagnosing them promptly and then managing them. So that's just a summary of how frontline work has been in the UK. Sadly, we've also lost 300 or more of healthcare workers in NHS. This is the latest figures as of today.
So being a cardiologist, you can also elaborate on cardiac patients being more at risk to this COVID-19. There's a lot of talk about comorbids. So would you like to elaborate on that?
Yes, initially from the data from China and then from Italy, and now our own data has shown that there are certain comorbidities which put you at higher risk of doing worse if you are hit with COVID. It doesn't necessarily increase the risk of getting infected with COVID, but if you have the infection, then your chances of doing badly increases. And they include things like hypertension, diabetes, cardiovascular disease like heart failure, cardiomyopathies, and age, advancing age particularly. Now, one thing to keep in mind is that this may not be a direct causative association. This might be a relationship because people who are elderly also have higher proportion of higher prevalence of the diseases. I mean, hypertension and diabetes is more common in elderly. Hence, it may just be a combined factor of age and comorbidity, which increases the risk. But definitely, having heart disease increases your risk of doing worse if you have COVID infection. Can you hear me?
So, yeah, Dr. Ghani, during your day-to-day practices,
All right.
what precautions have you been taking, or your cardiology colleagues have been taking while performing interventional cardiologists with COVID positive patients as well as COVID negative patients? Because being a surgeon, we have elaborate way of dealing with these, but you being an interventionist are at risk as well. So what were the precautions taken by you and your team?
Thank you for that question, Faisal. A very appropriate question, because here comes in the importance of PPE, personal protective equipment. So the first and foremost thing that we need to consider is making sure that PPE is adequately available where it's needed. So not just at the time of the procedure, this precaution needs to start even before that, identifying the patients who are at risk, identifying the staff who might be at risk and trying to put them away from high-risk areas. That's also as important as keeping the high-risk patients away from those areas. Talking about the procedure itself, now, the coronary angiography and angioplasty itself is not considered an aerosol-generating procedure. And aerosol-generating procedures are ones which significantly increase the risk of viral load and exposure. So this procedure itself does not generate aerosols. However, there's obviously exposure to body fluids, including blood, and therefore adequate protection is needed. So our practice has been that any patients who are suspected to have COVID, and importantly, if they've definitely been confirmed to have COVID, we have full protective equipment, including masks, which is FFP3 masks, goggles, face visors, and gowns. And we try and do those cases towards the end of the day, because the lab also needs to be deep cleaned after the procedure before the next patient can be brought in. So that's one precaution. Second thing to keep in mind is that cardiac patients during procedure can have a catastrophic consequence. They can have a cardiac arrest. So suddenly a stable situation can become an aerosol generating procedure. Cardiopulmonary resuscitation itself is an aerosol generating procedure. And recently there have been updated guidelines from Resuscitation Council on how to deal with these situations. And I wouldn't go into details of that, otherwise it will take too much time, but it's something to read. It's something worth reading and keeping in mind. Patients who suffer with cardiac arrest, emphasis has been made that the staff performing CPR must be supplied with PPE before they even start CPR.
So looking at the data from Hubei and Lombardy, and now the recent data from UK itself, What do you think, what cardiovascular manifestations and involvement have you been seeing more recently, which were not present previously?
So whereas previously the common presentations are chest pains, heart attacks, heart rhythm abnormalities, during COVID pandemic, we surprisingly saw a reduction in number of patients admitted with heart attacks. This, I don't think, is a reason. This is probably not because heart attack is not happening. I think it's probably because patients are apprehensive and they're not coming to hospitals. So we are expecting a late surge with late presentations. During the pandemic, the COVID being a viral infection, which was highly infectious, behaved like any other viral illness, and it was presenting in different ways. It did definitely increase the risk of blood clot formation. So we saw patients with clots in the lungs, clots affecting the coronary arteries, so causing heart attacks, and a higher prevalence of patients with inflammation of the heart muscle, which we call myopericarditis. That was definitely a presentation, and in some cases it caused significant rise in the blood test known as troponin, which is a protein that released from heart muscle. And the higher the troponin levels, refer to the worst prognosis. Some patients developed heart failure, requiring intensive care treatment, and these patients sadly did not do very well. So this was definitely a new thing for us. We had a much higher prevalence of myocarditis in the hospitals due to COVID being around.
Fahim?
Yeah, I'd like to just have a connected question to cardiovascular, and then we'll move on to Dr. Amir Burney. There's a lot of concern about the BP blood pressure medication that during COVID pandemic, obviously these patients do require some adjustment over the time, so they're not able to attend the clinics and OPDs. So, would you like to elaborate some enlighten on
Yes,
that?
I'll take it in two stages. One about the blood pressure, and the second about the routine clinics and procedures. So with the blood pressure, I think what you're referring to is that there was a lot of discussion about certain tablets like ACE inhibitors and
Yes.
angiotensin II receptor blockers. So for just to remind people, ACE inhibitors are tablets which end with pril. So ramiprils, lisinoprils, enalaprils, all these tablets are ACE inhibitors. And angiotensin II receptors are candesartans, losartans, irbesartans. So there was a hypothesis that these tablets, due to their pharmacological action, increase the binding of the virus to the lung tissue. Hence, there's increased risk of increased severity of infection. But that's just a hypothesis. That initially led to a lot of confusion, and there were some initial guidelines or papers coming out saying that people on these tablets should move to calcium channel blockers. But very soon after that, the European Society of Cardiology and the American Heart Association released their guidelines, which stated that people who are already on these tablets should continue these tablets, because withdrawing these tablets had a higher risk of causing deterioration in their heart failure status or their blood pressure being not too well controlled, which indirectly will cause a further increase in this or worsening the outcomes of infection. So they suggested continuing the tablets, and this was then endorsed by International Society of Hypertension as well. So the latest recommendation is to continue the tablets, but if some people have already changed, then try not to switch back and forth. Continue with what you're on as long as your overall heart status is stable. Second part of your question is about the clinics. So in most places, routine elective work was put on hold in order to accommodate for COVID patients. In our experience, in my hospital, we did not cancel any clinics. We merely changed them to telephone consultations. So we were still able to discuss things with patients on their scheduled appointment times. In terms of other procedures like heart scans, ambulatory blood pressure monitors, echocardiograms, or routine investigations and procedures, yes, they were put on hold. But cardiology procedures being the nature of what it is, a lot of elective cases also semi-urgent. So we selected amongst our own lists and brought patients in on one case-by-case basis. So we were doing about 20% of the work. This definitely delayed patients' access to secondary care. But our advice to patients was not to ignore the symptoms, and if they're still getting unwell, do not forget that emergency work is still going on. So they should not be apprehensive, and if they think they should need a hospital admission, they should present themselves to the emergency departments, irrespective of COVID status around.
Okay. Thank you for briefly elaborating. There were a lot of concerns about with patients and doctors on how to manage cardiovascular. We're going to talk about further on cardiovascular diseases. Now we're going to take Dr. Amir Burney. So it's an honor to have you once again as a president of APPNE. And we would like to have a brief summary of what is APPNE and, or how does it work. So that would be great to have your.
Well, assalamu alaikum again to everybody who's listening, and thank you to the Ziauddin Alumni Association for inviting me and to give me the opportunity to talk about the organization I belong to. In fact, Saqib also belongs to that organization, and so thank you, Faisal, and thank you for the opportunity. Now, APPNE, as we call it, is APPNE, which is the Association of Pakistani Physicians of Northern Europe, which is a nascent organization which sort of came into being about 2 years ago. And I, alongside other 4 executive members and 4 trustees, are the founding body of the organization. We took oath in February of 2019. So it's been just a year and about 3 months since we have been in place as an elected body. So APPNE is a democratic organization which came into being as a result of a lot of hard work by a number of alumni organizations coming together some years ago. And there was always talk about forming a singular platform for alumni who we could represent, and also to highlight issues of concerns and the European organizations and governments, and in Pakistan as well. So really, we are a 2-pronged organization. So we are a European organization which is hoping to look after the 2nd and 3rd generation European Pakistanis in Europe, across from Republic of Ireland down to Germany as well. And also working with our Pakistani colleagues who have come to UK or Ireland and made Europe their home. And as I said earlier, the aim is to work on a singular platform, highlight achievements, raise concerns, issues, take them forward to whatever government we need to take them to, or whatever organization we need to engage with. So, as I said, we had an organization which came into being in March 2018, was announced, and then formally we had an election in December of 2018. And I keep saying democratic because that's what we truly all believe in. And anybody who's a member of the organization can run for any of those executive posts, or office bearers posts. So, president, for example, general secretary, joint, or treasurer. It doesn't matter. So, you could belong to any alumni, you could run for any of those posts. So the elections took place in December of 2018, and we ensured that the elections are free and impartial. And we gave the contract to Electoral Reform Society of the United Kingdom. So they ran the elections, and then they announced the results. And thanks to Allah, I was able to lead the organization by becoming its first president.
So, Dr. Burney, we have been hearing the phrase frontline workers since this pandemic started. How do you define the phrase frontline worker, and what are the challenges faced by these people in NHS in particular?
Well, both in the NHS and in social care services, people who are on the front line will include certainly people who are in acute medicine, emergency medicine, ITU, anesthesia, and even surgeons, especially ENT, for example, or surgeons who work in very close proximity to the patients. So really, frontline boils down, and we can't forget the primary care physicians as well, GPs, because they are also working on front lines. So the front line, I think, became a misnomer, I must admit. I think everybody's working in the NHS, social care services, right down to the paramedic or to the porters who are working. They are working on front lines. So going back to when it all started, I think this is February, beginning of March, when we started to hear cases coming into the UK and other parts of Europe, especially after the virus hitting Italy and Spain quite badly. And very quickly, the UK health force, it's fantastic what they've been doing. But social services and NHS healthcare frontline workers were affected by it.
So what do you think, what are the real challenges faced by the overall healthcare workers, and especially the people non-white, or what we call as BAME community,
Well, as you know, I think the challenges was because this is a novel disease. It was, as Saqib said earlier, we did not know about this. I wasn't on one of the front lines. As I said, I work as a full-time academic, but I have many colleagues, friends, and family members who work in the front line. And the way the disease spread, the way it sort of happened, unraveled itself across the world, it was a new experience for healthcare workers and the patients themselves. So there are multiple challenges. And on the ground, yes, the challenges, as Saqib said earlier, was PPE was one of the biggest challenges we started very quickly about having adequate personal protection equipment, but not also having it adequate, but also using it properly. So there were guidelines, there were changing guidelines, or how to use them, who uses what equipment, at what level was another issue which we picked up very quickly. For example, in primary care, how much PPE is adequate, as opposed to somebody who is in the ITU, and how much PPE will they require. So availability of PPE, I think, was one of the biggest challenges we saw unravel very quickly. And then as the disease made its way through the communities, and then the healthcare force very soon, I think very early on, correct me Saqib if I'm wrong, but very early in March, it started to become clear that the BAME community, the Asian ethnic minority community members are at risk, both in the community as well as in the healthcare force. And as you all probably know, that these are factors or variables still being investigated. So many hypotheses were put out there, from vitamin D to lack of PPE to diabetes, hypertension, other comorbid conditions. But I think at the moment they are still being tested, and they need to be researched both diligently and completely, so that whenever this pandemic happens again, we are prepared for it better.
So we got a few questions from our audience. First question is, one Facebook user asked Mr. Burney, how is APPNE supporting BAME colleagues in different trusts? I would like to add that what was the role of APPNE in taking care of the mental health issues or the mental health challenges of the community as well?
Well, what we did very early on, we identified issues not just with our healthcare force, but everybody, literally across the board. So healthcare professionals, whether they belong to any community, are our colleagues, and we need to look after them. And then the IMGs, international medical graduates, who were either stranded here in this country because they were here to do placements, or they had finished their plans looking for jobs, or they had given the exams and they had to go back to Pakistan or other countries to get their visas converted so they can come back and work here. There were issues with the GMC, with the IELTS, the OET English test, and also with, for example, the good standing certificate and availability of it. So the challenges were really a number of challenges. And then, as you know, if there's a challenge, it adds to anxiety and mental health. Because of the way the diseases were spreading in the community, and people were then told to stay home and completely isolate themselves. There were people who were shielding themselves, and people who were became unwell, had to stay home for 2 weeks to begin with. There was impact. So what we did as an organization, we are fortunate that in our midst of nearly 470 members now, paid membership, we have a number of very competent psychiatrists who very quickly then conducted webinars, became part of discussions, media channels here in the UK, as well as on radio channels as well. So just to raise awareness around mental health, how to tackle it, how to overcome the anxieties associated with the condition itself. So our psychiatrist friends in APPNE and beyond APPNE as well did a series of webinars, talk shows on television, and radio channels as well.
One thing, if I can add to what Dr. Burney just said, in addition to what he said, yes, I agree. The other thing we did was, if we ever came across news of somebody who's admitted to hospital, particularly who do not have family members around, then we use our own connections to try and get hold of someone nearby, or at least get in touch with them through social media, because they were still using WhatsApp while in hospital, just to keep ourselves and them up to date, or at least get their family members up to date. From Pakistan, they kept contacting us, inquiring how their sisters or brothers are. So we tried our best to try and bridge the gap of communication as much as we could.
Indeed, and I must say to it, there are so many of our colleagues, again from all communities, who came to support our friends who were unwell or unfortunately had lost their lives, and then offered support to their families both here in the UK, Republic of Ireland, and in Pakistan.
Fazil.
Dr. Saqib, I would like to come back to some cardiovascular related queries we have, and a lot of audience are interested to learn about it. So there's a concern that is there a higher risk of having a heart attack, acute coronary syndrome during the COVID-19?
So, as I briefly touched upon this earlier, the COVID itself, I don't think increases the risk of heart attack. But what we noticed was that people were either ignoring the symptoms or not presenting to hospital early enough. So we saw actually a reduction in hospital admissions due to heart attacks. But the ones who did come in had worse heart attacks or a bigger heart attack. So I don't think it directly increases the risk, but it causes thrombogenesis, so the blood clot formation increases, and that indirectly can cause blood clot formation in the heart arteries, causing heart attacks. So we've certainly seen some cases who had blocked arteries because of a blood clot, and they had COVID. So that's all I can say on that issue.
And how does your hospital, or how did your hospital cope up with the routine cardiac investigations and procedures? Like you already highlighted about the PPEs, since it is not an aerosol generating, but how was your hospital experience? Would help others.
Yeah, I think it was a combination of clinical and management team coming together, and making some clinical decisions and some administrative decisions to help smoothen out the process. And this included, to start with, before coming straight to cardiology, because the process starts when the patient comes into an emergency department. That's where that's the front line. That's where the first experience or first exposure happens. So what we tried to do, which I think other places, maybe in Pakistan, should also consider doing, is try and delineate or demarcate wards and divide them into so-called clean and dirty wards, or COVID or non-COVID wards. Because what that does is it reduces the cross-infection between the wards and tries to minimize the spread amongst a group of patients. So for instance, at one time we have 450 beds, but we had roughly 200 patients with COVID, but most of them were in selected wards. So that's one way to manage things whilst patients are in the hospital. Second thing we did in terms of cardiology is that elective procedures, as we said, were put on hold, but not all of them. We sub-selected a certain number of cases within our elective list who we thought was semi-urgent. Otherwise, they had risk of being admitted due to an emergency. So we contacted those patients, made sure they were still happy to have it done, and then did them. But in doing so, we had limited our lists down to 1/3 or even 1/4. What that allowed us to do was have more gaps between the patients and not have them on, consecutive beds in the waiting area or consecutive chairs in the waiting area. We created more space in the waiting area so that, social distancing can still be practiced as much as possible. So that's one way of reducing the burden. And then finally, we basically had to triage our waiting lists, and most patients obviously were put on hold, but then we had to select the ones we thought was still needed. So that's the elective care that we had to manage.
There's a comment.
Then comes staff management as well. So whilst we reduce the elective list, obviously a lot of the nursing staff who is often busy with the elective work has some more spare time to their hand. So there was sickness around, people on the wards were getting off sick, including nurses. So that's where our additional role came into play. We had to depute our nurses and colleagues into other areas where they didn't previously work. So I think it was a combined effort of seeing where the gaps are, trying to plug the holes with other staff members and cover each other.
A quick comment on a query just we received. More than heart attacks, I have seen VTE and PE, although post-infection they may have myopathies. Are we planning to do a follow-up echoes in this lot?
Yes, the at least the cases of myopericarditis we had, the ones who managed to go home, we definitely do need to have to bring them back in a few months to repeat their heart scan, including a echocardiogram. How we treated them whilst they were in hospital, it was varied. We used colchicine in some cases. The ones who were admitted to intensive care had methylprednisolone or other high-dose steroids used as well. So the outcome varied depending on how sick they were. But the ones who did go home, yes, we will definitely bring them back for a follow-up scan. In terms of research, I personally have not been involved, but there are lots of centers in London who've been taking this up. They are following them up very closely. We have one of the world's largest research trials running in UK called Recovery. It had 5 or 6 arms, so patients were recruited at various stages, and results obviously will have to be awaited, and we can't comment very early on.
Briefly, if you would like to, there's been a recent shift on telemedicine, and seeing patients, via, and sadly, doctors and graduates from our part of the world are not fully equipped and trained or tech savvy to adapt this sudden change. So what's your experience? And I would like to also have some comments from Dr. Amir Burney.
Very, very valid question, and I think very topical. I think, just on a lighter note, I'll tell you this. We had an NHS 10-year plan just only a couple of years ago, which meant that in 10 years from then, a lot of our consultations should move to telemedicine. But by the virtue of this virus, we managed to deliver that in 1 month. So this is the future, telemedicine and use of technology. There are a lot of secure portals which hospitals are signing up to, where patients can consult the doctors using their iPhones or iPads or computers. We must not forget, it's not just the doctors who are not tech savvy. A lot of the patients, particularly who are elderly, they are not tech savvy either. So it's a two-way challenge. So in some cases we have to use the technology. In some cases we are still learning how to use it. And in my experience, I still have to occasionally bring the patient back to see them physically, because cardiology relies a lot on physical examination as well. So every specialty has to, I think, adapt according to their own needs. This is where I think the new guidelines should be very flexible. There shouldn't be a generic rule that should apply to everyone. Dr. Amir Burney has had orthopedic experience there. Unless they see a joint, they can't make a decision on it. Unless I hear a heart murmur, I can't tell you how bad it is. So certain patients definitely will need to be seen physically. So there needs to be an element of flexibility, but clearly technology is the way forward. And hence we are here talking to each other. This would not have happened without technology.
Dr. Amir Burney, your comment?
I would totally agree that moving forward, technology will have a big role, AI technology in healthcare services across the world, and not just in 21st century UK or Europe, but also across countries like Pakistan, even African countries, how we reach out to our patient cohort. So APPNE has been fortunate that we are now engaged with the government of Pakistan in 2 major projects. One's called Yaran Watan, which is the Pakistani Diaspora Health Initiative. We are a signatory to the document and to the team in advisory capacities. And given the COVID-19 crisis, they are now putting in a telemedicine project, which is the first project to start. So all of my colleagues out there, medical colleagues, they can sign up to the Yaran program through their portal and offer your services. And depending on your area of expertise or how much time you can give, you can work on this project to begin with. Secondly, APPNE is obviously going to strive for academic, education, social, and other altruistic activities. But we worked very recently with some organization called the National Incubation Center of Pakistan. I don't know if you've heard of it, which really take ideas, entrepreneurial ideas from communities of scientists, medics, business people, technologists. And we were fortunate to actually sit and look at some of those ideas recently as part of the partners on the Pakistan project, as we call it. Some fantastic ideas. There were chatbots, there were WhatsApp groups being formed for patients to access in rural areas of Pakistan. There were telemedicine projects which were running on 4G or 3G even. So that is the way forward. And as I said, if any of your colleagues or my colleagues, medical colleagues, want to get in touch with the Yaran program, you can either approach us or you can go straight to the website and register your interest.
Okay. Dr. Amir, we would like to have your input on how APPNE is facilitating during, you've already told us how APPNE is helping Pakistani doctors in COVID-19. So in general, how does we did listen to your session on 17th, and we shared the video on our page as well, and people were very happy about the initiative you took. But in general, if you can let our young graduates know how APPNE facilitates, besides this COVID pandemic, and international medical graduates, especially coming from Pakistan.
Absolutely. Because as I said, we have two homes. We have Europe as our home, whether you live in the Republic of Ireland, Germany, Norway, Sweden, Denmark, where we have Pakistani as third or second generation medics, and or you come to Pakistan and start your life in UK or Republic of Ireland as an overseas international medical graduate. So there are two separate streams of people we are working with, and I think we are working with both of them pretty closely nowadays, and the issues are different. So, for example, those who are coming from Pakistan, the issue could be life in UK as a medic. It's completely flipped to what you have as a life as a medic in Pakistan, whether you come from Lahore, Islamabad, or Karachi. The support structures you have of friends and family is no more. When you start your own life as a medic, as a young medic in this country, and then you have to face the challenges, you look after your training, exams, and so on and so forth. So one thing which we are looking forward to do is to form this fraternity of medics, where we can offer not just education, academic activities, but also a social platform where you can reach out to us. Recently, in this COVID crisis, we sent out an email to all our membership saying if anybody was in need of any help, get in touch with the task force. Saqib sent that email out recently just to see where people are, because sometimes as medics we are guilty of just carrying on and not seeking help because we think we just carry on. We are supposed to do that, but you must remember we are human after all, and crisis will impact on us both physically and mentally. So the idea is to reach out not just in terms of education, but also in terms of social contact, and to form platforms where people can engage with each other and help each other, whether it's a young or it's the senior, it doesn't really matter. So moving on to what you said earlier about how we are helping. So for example, just to give you some examples of what we did recently was to help people who were stranded here immediately when the flights were being shut down. Was to very quickly engage with the High Commissioner of Pakistan. And I must say, the current High Commissioner, His Excellency Nafiz Zakaria Saab, has been extremely supportive of what we have been doing as an organization. The Pakistan High Commission has been second to none in supporting us in getting people from here, from UK to Pakistan, and getting them the flights if they wanted to. Also, there was the issue of finding jobs. So with our task force, we have found a number of IMGs, not just from Pakistan, but actually from other countries, neighboring countries as well. Jobs up from north of England down to south of England. And again, Saqib has been one of the key people in getting those people the jobs, getting interviews and helping with the CVs and sort of facilitating and not getting them the job. They have to do it on their own to get the job, but helping them, facilitating them. And then issues with the GMC, right? The GMC about extensions. We wrote to the Home Secretary a number of times about visa issues. As you know, 31st of May was the deadline for many visas to expire, and that was extended. We were probably one of the contributory people to it, not just the only one, because many people have been writing. Public Health England, we recently written to them. We are collaborating with nearly 16 game organizations in this country, right, from the British Islamic Medical Association to British Asian Federation of Indian Origin, BAPIO, one of the bigger organizations, DAUK. So our focus is not just inward. We're not just looking towards our own Pakistani doctors from abroad and from here, but also to diversify and include organizations which are other organizations.
Yeah. And Dr. Saqib, we would like to have your opinion as well, since you're very reachable by the young graduates. So the real question is there was already some concerns about pre-Brexit and post-Brexit, for especially people coming to UK for. So now it's a combination of pre and post-COVID and pre and post-Brexit. And to add the situation, make it more worse, we have a PMC and PMDC issue. So your comments on that, what you've been hearing.
So if I'm honest, I'm not entirely up to date with the PMDC and the PMC issue. So I wouldn't comment on that. Dr. Burney probably is. But yes, coming to the other stuff, yes, we've been to two phases. You're right. There was a Brexit issue, which has put a lot of things on hold. Then came COVID. But with every downside comes an opportunity. So there was a short window of opportunity, as Dr. Burney has mentioned. During the COVID, some hospitals were getting short of staff, and some staff was looking for jobs. So we managed to squeeze in a few here and there, get jobs where there was opportunity, and then we couldn't fit everyone else in. But going forward, post Brexit, I think there may be some apprehension on behalf of European doctors, and a less number might be coming to UK. That's my feeling. And as a result, although in the short term the COVID has muddied the water, but once the situation settles down, there may actually be more chances or more opportunities for people from Pakistan and other Asian countries to take up posts which were previously taken by European people. So I think, although Brexit has its own flip sides and positive and negative aspects, but for people coming from Asian countries, the opportunities might actually increase going forward. The technicalities behind that may be challenging, but that's for the experts to comment on. But definitely opportunities will come up. As far as I'm concerned, yes, you're right. I am approachable. I don't mind being approached, at odd hours or 7 days a week, because I myself went through this process. And at the time when we were going through this process, we did not have social media. We did not have WhatsApps. We did not have Facebook. We did not have these groups where we could sit together and talk to people. And we had to put a lot of effort to, go out of the way and find our ways. So hence, I understand the challenges that IMGs face. And I personally am very happy to be contacted. And as much as I can in my busy schedule, I do try and respond promptly. So yeah, if any of your colleagues want some advice, yeah, me and my colleagues, I'm sure will be very happy. And I can say on behalf of Dr. Burney as well, we'll all be happy to assist.
Dr. Burney, we would like to have your comment on this, and then we are very honored that you've given some precious time from your busy schedule. So a quick comment on PMDC and PMC issue, and then end remarks, and we'll continue with Saqib later on.
I must say the honors are mine. Thank you for inviting me once again and giving us this opportunity. And I think networking is key to progress. Unity is our strength, and we are very diverse in our specialties where we come from, age, for example, sex even. But the diversity is the strength of any organization. And I must say that people like yourself, who are keen, motivated, younger than me, I keep saying this, they will be the backbone of the organization. We've done the founding of the organization, laid the founding stones. We will move on, and we have to other things and other parts of our life. But you guys have to join us and be the backbone of it. Now, going back to the GMC issue and the PMDC and PMC, that was one of the issues we identified as a task force we formed very earlier on in end of March. In fact, beginning of March, the IMG task force and headed by a few members of the executive committee, we worked very hard on it. And one of the issues was to make sure that we have a portal of communication with the PMDC or the PMC or people in Pakistan, as well as with the GMC. Because there was issue of the good standing certificate and with no PMDC registrar for the time being, there was an issue. But the PMDC was restored, as you know. So PMDC was restored, and now it's working. There's a registrar. There's a faculty for getting your good standing certificate. I must say that there was an issue with the IELTS and OET tests in danger of expiring and people not having the certificates in time. The GMC we have spoken with, and GMC's come back to us saying all people who are affected by this should get in touch with the GMC advisors as soon as possible, and they are dealing with them by case basis. So that's been highlighted as well. In case you are in that sort of boat of trouble, the PMDC is now going to be shut down because of Eid holidays. So people have to be very careful that if they're going to send for a good standing certificate in the next week, it may delay it by a few days. So you have to be very careful that you are applying today and make sure that you are getting your good standing certificate well in time. And if not, then I have written down my emails for you, corporateaffairs@appne.uk, info@appne.uk, our Facebook page. We are very easy to find. Literally anybody who's reached out to us as a team, through our Facebook pages or messengers, or found our numbers through wherever they found them, we are more than happy to help. So literally, that was last century, as I say, last 21st century is an all-new century where we are coming together to help each other. It wasn't the case many years ago, I can tell you that.
Exactly. Thank you, Dr. Amir Burney. We'd like to just end this session from your part. We're going to continue with Dr. Saqib. And it was a pleasure for ZMC Alumni to have you and host you. And we look forward to more collaboration and have our graduates be member of your prestigious organization. Thank you so much.
Absolutely. I would welcome you all to be members and to be a part of these processes and give us your support and advice, which is very, very important. So thank you, everybody. Assalamu alaikum.
Thank you very much, Dr. Burney. So we move on with further some cardiology-related questions to Dr. Ghani.
Yeah, sure.
Looking forward, say 3 months or 6 months, what do you think? What would be the impact on the cardiology services, and how are you going to tackle with those issues?
Good question. We have recently started having meetings amongst our colleagues and management to try and discover what the new normal is going to look like, because post-COVID era is not going to be the same as the pre-COVID era. So taking maybe if I dissect this into two areas, one is routine elective work and the other one is inpatient work, emergency work. As far as inpatient work is concerned and emergency work, I think the focus will shift towards getting the procedures done as soon as possible so that patients do not stay in hospital longer than they need to. Because if they spend a long time in the hospital, firstly, they have a chance of getting infected. And secondly, if they're asymptomatic with the infection, they have a chance of spreading it to other people as well. And like other hospital-acquired infections, COVID is now right on top of that list. So to try and get them out as soon as possible, that's a priority. In terms of patients with heart attacks, we probably have to look into high-risk acute coronary syndromes and low-risk acute coronary syndromes. And some acute coronary syndrome, we might even discharge with a very early outpatient angiogram within the next 2 to 3 days. And that we've already started doing, which has been safely practiced so far. And then coming on to other services, I think we probably will have to wait and see until the lockdown is completely over, because although we're resuming our services, we are resuming it in stages. So we don't want to open the doors to all patients at once, because that again increases the risk of cross-infection. So we are doing it in stages. So at the moment, it's probably 50% of the work and gradually building up to 100% capacity. And as we do that, we have to also watch what COVID does. Is there a second surge, further down the line? If there is, it will once again delay things and we'll have to, adapt again. But going forward, I think the virus is here to stay. It's not going to go away. We had influenza how many decades ago? We still have influenza every year. We have vaccines for other diseases like measles, mumps, typhoid. The diseases are still here. So similarly, I think COVID is here to stay. The world will learn to live with it, and so will the healthcare facility. I think they'll have to adapt to deliver the service with COVID around, and I think the new norm will be making sure there's social distancing to a certain extent, not to avoid overcrowding of patients or relatives. Keep talking of relatives, we may have to think about policies where we limit the number of relatives coming in with patients. So it's maybe maximum of one person. I think the whole world will have to just adapt to this. Now, particularly cardiology, I think with this higher number of patients with heart failure and myocarditis, I think there may be a long-term impact on these people. They will require more cardiac rehabilitation. The excess tolerance will be reduced. Their functional capacity will be down. So that probably might have an impact on their personal health, as well as overall cardiovascular morbidity and mortality going forward.
Since cardiology has a direct correlation with diabetes and obesity, how do you see these two also evolving while people are sitting home and gaining weights and not going to their cardiologist or not going to the diabetologist for adjusting their doses? Do you think severity of disease will also increase with time?
I think there is a chance for that, definitely, because technology and learning to use technology will lag behind the disease progression. The disease will not wait for us to learn how to treat it with new technology. So people who are at home and have been waiting for treatments, or unfortunately ignoring the symptoms, are at high risk of the disease progressing. We've already seen some cases who presented very late. So the advice I have is obviously that as much as the hospital attendance or the footfall is low, patients should not avoid approaching medics. Wherever they need to have healthcare input, they should contact their family physician or GP, as we call them in UK. They should seek attention. Advice is still available on the phone, if not physically. And then after phone consultation, doctor can then decide who to see physically. So that's the new way of dealing with things. Although it seems that there will be less work done, I have a feeling once people learn to use technology, they might be able to actually discuss more patients in the given amount of time, and then pick up the relevant ones who they need to see physically. Maybe there was a lot of burden on the NHS in the previous years. I just have I've been thinking and discussing with colleagues, A&E admissions have gone down 50% in the last 2 months. They are picking up again. But in news or anywhere, we did not hear about people dying at home just because they could not get to A&E, which meant that previously a lot of people were coming to A&E department who did not need to come to emergency department. So I think people will also, learn the tricks and then use other paramedical staff, pharmacists, who can give useful advice. That's probably the way forward.
All right. Dr. Faisal?
Yeah, so a few more questions. So since the emergence of this COVID-19 pandemic, we have seen the availability of the resources, webinars, courses, which are obviously free of cost at this point in time. Do you think this trend is going to continue from here onwards, or are we going back to, again, paid learning in few months down the line?
Very well question. The use of webinars and technology, I think, is here to stay. I don't think it's going to go away. I can't think of any technology in my lifespan which once emerged on scene, then went back in time. Things only evolved in future. So webinars is definitely the modern way. Every week we've been having our multidisciplinary meetings amongst various hospitals, and that happens using various portals. I'm not going to name any for commercial reasons, but there are lots of portals around which we have used. That has eased and given us more opportunity to attend those meetings. Previously, we used to spend time traveling, and that time can now be used doing some other work. Definitely, being humans, we like the human factor. So some webinars, probably, I think we'll have to think carefully. Some webinars where the attendance is small will definitely do well with this kind of online setup. But big teaching sessions where the attendance is expected to be high, keeping in mind that a lot of the audience will be silent behind the scene and not be able to communicate directly with the presenters, limits the ability to actually learn to some extent. So I think for the larger audience, we probably will still have to go back to a certain extent to our conventional way of teaching, where we had one-to-one contact or group sessions held. Because don't forget, communication skills is a major part of healthcare provision, and learning body language, how you communicate with colleagues, your eye contact can never be the same on camera as it is one-to-one. It's like comparing watching a movie on television compared to watching a movie in cinema. We pay more to go to cinema. I would never give up that experience for anything else. So similarly, we'll have to choose and pick. Some things will be suitable for webinars, but some things will probably have to go back to conventional methods of training.
Right. So, Dr. Ghani, how do you compare the situation between Pakistan and the condition and the situation in UK? We have seen the flattening of curve; the cases are coming down, while on the other hand, in Pakistan, the cases are going up. Do you think it's going to follow the same trend in Pakistan, or is going to wean off slowly rather than going to a peak?
Okay, I mean, I'm neither a virologist nor an epidemiologist, but I mean, from anecdotal evidence, I can say that in UK definitely we've seen the peak past us. We're definitely past the peak now. The curve is coming down. The daily infection rate has gone down. Comparing that with Pakistan, I think Pakistan was a few weeks behind to start with. Every country had its own time scale. So I don't think Pakistan has peaked yet, and that is my worry. The healthcare resources are limited in Pakistan, particularly the availability of intensive care beds and units, ventilators. So whatever we need to do to prevent the spread. in Pakistan. The biggest challenge in Pakistan, I think, is not just the disease itself. It's a socio-economic status and the general, you can't compare one country with the other. So for instance, in UK, we have healthcare which is free at this point of delivery. And also it's a welfare state. It's the sixth most, financially viable country or financially strong country in the world. So comparing UK to Pakistan is probably not a direct or fair comparison. In Pakistan, the challenges are far beyond just the spread of the disease. And as much as we need to protect people from getting the disease, I can understand the concerns regarding financial crisis. So I won't go into details of that, but Pakistan has not peaked yet. The numbers are growing, and it's a worry that the numbers can grow very quickly. And if it follows a trend that UK followed, then the next 2 to 4 weeks can be quite critical.
Yeah. So we would like to also know that not only healthcare workers working in whether in UK, in Europe, or US are not only considered as doctors working abroad, but as overseas Pakistanis who the Pakistani community look up to for contribution, whether that's technically, financially. So we weren't able to ask this particular question from Dr. Burney, but you can comment on that. How this role has been played by APPNE and the Pakistani community doctors to support Pakistan in this pandemic.
So, as Dr. Burney was mentioning earlier, APPNE and Pakistani doctor diaspora have been recently been involved with Pakistan government officials in launching the Yaran Watan program, and we are signatories in that program as well as some other organizations. So that's one of the ways where hopefully in future Pakistani doctors who are abroad will be able to deliver some services for people back home. So that's the clinical aspect or the medical aspect. Then obviously financially, it's about raising funds and donations, and there are certain reliable people who have approached us from time to time, and we have managed to collect some funds and then delivered in the accounts, which have been used to provide emergency services related to COVID in Pakistan. So I think it's an ongoing process and likely to continue long term.
Dr.
Dr. Ghani, have you? Yeah, a few more questions. Maybe we are getting towards the end of the session. Now, last question is: what are the ethical challenges have you faced, or when I say you, it means the broader cardiology community in addressing the victims due to the critical care triage or the prioritization of the services?
If I got the question right, the ethics. Well, firstly, every patient is treated at par. Even the Prime Minister of our country was admitted to a unit where other patients, were being treated. So that's the beauty of NHS and welfare state. But the challenges that we face with COVID is particularly related to decision making about which patients might be suitable for intensive care treatment if needed. And that's often a challenging dilemma because these are situations where family members are not around. Patients are on their own. Usually you can approach families on the ward rounds, but here they were not allowed to come into hospital. So a lot of factors have to be taken into account. And then the decision is not a single-handed decision from a cardiologist or even a lung specialist. We are not, cardiologists are probably third line in this, chain of defense. The lung specialists are much, more involved with dealing with these patients. But in our hospitals, or in my experience, it's actually the intensive care specialists who we get hold of. They are the ones who come and discuss with the patient. They explain in detail what are the benefits or potential problems associated with being admitted to intensive care unit. And finally, you have to balance out the supply versus demand. Luckily, in UK, the ventilators did not go short. We had to expand our number of ventilators, but we were able to do so. But a lot of patients who previously may have appeared to be fit and healthy, once they developed COVID, became very frail. and then their chances of improving on a ventilator was very low. So that's where the ethical dilemma was, and that's where we got help from our expert intensive care specialists who took over the care and helped us make those decisions.
I just received questions on my WhatsApp. There was a concern that there were more cases, positive COVID cases and death among the South Asian communities and South Asian healthcare workers. What say you have? What data do you have and about this?
Yes, in UK, sadly, more than 300 healthcare workers have died. Now, until a few days ago, almost 35 doctors had died. I'm not entirely sure of the up-to-date number now, but I think almost 33 out of 35 belongs to BAME community. So that's a huge proportion, and it's if you look at the proportion of population which is BAME, there's a higher proportion of BAME actually working in healthcare, but the number of people dying from this was much higher. There could be various factors, and I think there are lots of studies being done which still haven't answered as to why that might be. Some have hypothesized a vitamin D deficiency in BAME community, which can be linked with worse outcomes. Some have mentioned that there's higher prevalence of hypertension and diabetes in this community. Obesity is also more prevalent, and that these could be contributing factors. Some other factors could be the socioeconomic status and the fact that a lot of people in these communities or a lot of family members also work in the same sector. So there may be more than one people in the household working in healthcare, which can amplify the viral load at home. If there's one person is exposed, the other person is bringing more. So there are lots of factors. But yes, definitely a much higher proportion of South Asians, Afro-Caribbeans, and these people have been affected. Filipino nurses have been affected. It's not entirely clear. There may be some genetic element as well, but I think time will tell.
All right. Dr. Saqib, thank you so much. We would like to end this session. Greatly, achieved what our topics for today were, to talk about cardiovascular diseases in details, frontline workers, and APPNE. And we definitely would like to have another session on cardiology after this COVID-19 and after Eid. We're going to plan with one of our alumni who happens to be a good friend of you, Dr. Nadir. He's also a cardiac thoracic surgeon. So thank you so much for your time and collaboration and arranging this session on a quick note. So last remarks from you and any advice you would like to give to alumni.
Well, once again, thank you so much, Faisal and Fahim, for inviting and giving me and my colleagues the opportunity. It was my pleasure to be on this platform. And it is a small world indeed. You mentioned your colleague, Dr. Nadir Naeem. He's Mr. Nadir Naeem, as we call it in the UK. Surgeons are Misters. So he's a cardiothoracic surgeon in London, and I'm a cardiologist in London. So we both would love to come together and produce a useful session on cardiology. Yes, we are at your service. Final words, I think, look after yourselves. Make sure you are well protected. Make sure your family members are safe and your work colleagues around you are safe. Because if you just think about it this way, if you can ensure that your staff members are safe, your nurses, your junior doctors, your trainees, your colleagues who sit around you on the tables in the office, if those people are also safe, you are even safer, because you are more than likely to get infection from them. So as far as COVID goes, just don't look after yourself, also look after people around you. And if everyone does that, then I think there's a higher chance that people can be protected from this. We all have to go to work. We can't stop working. It comes with the job, and I think we're privileged in these challenging times that God Almighty has chosen us to be at the front line. So we should take pride in what we do, stay humble as we go along, and just do our best for patients and our colleagues.
Thank you once again, and especially thank you to our viewers. As it is already scrolling beneath the video session, that you can take membership of APPNE by accessing their website. Dr. Amir Burney also mentioned the email addresses, which is also scrolling under your screen. and you can join their Facebook page and group to reach out these wonderful people. Thank you once again, Dr. Faisal.
Yeah, I would like to say to all people out here in UK, Ireland, and Europe to join the WhatsApp group to start with. There are a few more things coming up in future. So be connected, be supported. Together, we can defeat this disease.
And if I can add a final word, yes, because Dr. Burney is not here, on his behalf, that all Ziauddin alumni, we on behalf of APPNE team would like to welcome you all. This is your organization. It's inclusive. Everyone should be a part of it. And together, if we go forward together, I think we can make it stronger. And the stronger it is, it can help everyone. So please join us.
Yeah. Taking from that note, I think I would like to suggest Dr. Faisal that you can take a group membership from APPNE, from your platform of Ziauddin Medical Graduates. You know.
Yes, definitely worth having a discussion. Thank you.
Thank you very much, Dr. Saqib Ghani and Fahim.
Thank you.